Hi, and welcome to another edition of the Trustcast Show. And we're really excited to have with us Dr. Alison Kole, a sleep doctor. Welcome to the show, Doctor
Thank you. Thank you
Alison.
so much for having me.
I'm glad to have you. So, Dr. Alison Kole is a triple board certified sleep medicine physician who spent years in the ICU keeping the very sickest patients alive. And the whole time she was a chronic insomniac. So, the COVID pandemic broke her own sleep so badly that she pivoted her entire career, built a concierge telemedicine sleep practice, and now hosts the Sleep is My Waking Passion podcast, where she calls sleep your most underrated superpower. So I have I'm going to ask a lot of my own questions in here because I have sleep issues, as many people do. So you're a sleep doctor who couldn't sleep. How long did you live with that irony before you decided to do something about it?
Oh, that's a fantastic question. Um, I would say that I really didn't even prioritize my sleep. My training, just by way of kind of introducing how this all started, I probably started not sleeping well as soon as I decided I was going to be pre-med. So you go through that whole process and it's like burn the candle at both ends. Can I get an extra question right? How do I get a leg up? Nobody ever talked about sleep way back when. Then, you go through your internship and your residency and then pulmonary critical care, especially around that time, we really didn't focus on sleep. It was really not anything that was emphasized or discussed in curriculum. I didn't really even think about it as being a thing. My main exposure was just in treating obstructive sleep apnea during my pulmonary fellowship.
Hmm.
And I knew that I slept poorly, but I also knew that I felt like my superpower is, I have the attitude that I'll sleep when I'm dead. I don't need to worry about sleep. Like, I'm invincible. I'm a little bit of a superwoman. I just really thought that that was my reality.
It
And what
sounds
just
right to me.
Right. Well, what happens is you just get older, you age, and then that flexibility, your life changes. You start to have kids. You have different responsibilities. You become an attending, and then you're worn down by all of the call and the responsibilities that you have. And so it was really like slowly over time I began to really see the detriment in my sleep. Once I decided after pulmonary fellowship, because sleep fellowship is a separate fellowship, I came back and I did a year of sleep fellowship where I did call every once in a while just to keep up my ICU skills. But I really primarily just did sleep for that entire
Hmm.
year. And for the first time in my entire adult life, I started sleeping very regularly. And this idea of having trouble sleep just did seemed to start to melt away. I always had some anxiety about going into sleep, but for some reason that year when I wasn't constantly pressured to be on call or have somebody bug me in the middle of the night, I just life got a lot easier. And I was like, this is glorious. And then I went back, of course, and started working and doing my pulmonary critical care and sleep thing. And then I would really be very strict about my approach to sleep. I really did essentially a form of cognitive behavioral therapy on myself. And things would be okay. Then I would go
So
into my
explain
week of
that to me.
Sure. So, cognitive behavioral therapy for insomnia is the most evidence based way to take care of your insomnia. The success rate is on the order of about 80% of most patients. And, if you compare that to any sleeping pill, it's going to knock it out of the park. And really, it is focused on several different things. Yes, there's your behaviors and attitudes towards sleep. But then there is also a reconditioning process where you're essentially using neuroplasticity to retrain your brain to see the bed as being a sanctuary, a place of respite, decreasing that sleep anxiety, having you sort of re see your approach to sleep and the bedroom and your nighttime routine as being really fundamental to your sleep. It also means that you're really reserving the bed for sleep and for nookie. So if there's no nookie happening, it's just for sleep. You're not hanging out doing studying or reading or watching TV, that sort of thing.
That was my next question. So when I tend to go into the bedroom, I I will start by picking up my Kindle, not so much my cell phone, because the cell phone is too just distracting, the blue light and everything about that. But the Kindle, I have it set on the white on black, and you're telling me to stop doing that.
Well, I'm gonna I don't want to tell you to do anything absolute. I think what you need to reflect on is what you're reading on the Kindle something that allows you to relax? Having anything with a backlight directly into the eyes, you just have to be very careful about brightness. That's perhaps the most significant influencer of what might disrupt our circadian rhythm, is how bright that backlight is. But if it looks more like a paper and it's not too bright and you find it relaxes you as part of your sleep routine to be able to get to sleep, great. If you find that you're reading and continuing to read more and it's not allowing you to relax for sleep, then maybe the better part of valor is to get out of bed. And if that's part of your wind down routine, indulge in that. But give yourself grace and also a time limit for what you're going to do. Ask yourself, am I reading this? And is this material that I'm reading something that's relaxing me to actually have my eyes get heavy and go to sleep? Or is it stimulating me, causing my brain to now think, and now I can't shut it off? Because perhaps you need to think of a different way to relax. Everybody's going to be different.
So if I actually am, I like to read, but when I get into bed and I start reading, it's kind of frustrating because I just like pass out. Even so, I'm reading like the Slow Horses books, which are really high anxiety. But for me, I just can get through like 5 pages or maybe 8 pages, and then I'm zonked out. But then,
That's a blessing. That's a blessing.
yeah,
That is your
but then,
pacifier to get you to sleep. Okay,
yes, it
listening.
is. So, but then about 2 or 3, and I notice in here something you said. You talk about a 2 to 4 a.m. wake up, says the witching hour. So I always go out of order. I have all these questions and then I go out of order. But then around in that witching hour, I will just wake up, and I wake up actually with a headache. And I don't know if that's a sign of sleep apnea or something else that's going on. But I'm not I'm not a constant snorer. Every once in a while I snore, but my wife says, you're not really a snorer.
What do I
Well,
think
now I'm
about that?
asking, huh?
What do I think about that? What time are you getting to bed?
I usually get to bed about 9:30, something like that.
And you're asleep by like 9:45, pretty quick, if that.
Yeah, it's
10
like,
o'clock, something like that.
unless my wife, she likes to see what her pacifier is, you watching TV, and that is forget it. If she watches TV, then I'm just like, my eyes go open. She falls asleep in 5 minutes on the TV, and I'm like glued to it, like watching the whole thing. I can't go to sleep with the TV on. It's just like we're the opposite that way. She reads a book and that wakes her up.
Interesting. So are you guys sharing a bedroom, or do you kind of do a sleep divorce where you sleep in separate rooms?
No, we do so we share a bedroom. Yeah.
So she's got the TV on. Are you the one who sees her asleep, then you shut the TV off, or what happens?
Yes. Unless I
Okay.
get addicted to the show, and then I watch the show, and then so it's really bad, that part of it. So maybe I need a marriage counselor here too.
What I would encourage your wife maybe to watch TV outside the bedroom ideally, but if that is not what she's going to do, if she has somebody to shut it off, or you can put it on a timer, that's another workaround. That's good. And then, just the reason I asked specifically about the timing is every hour and a half to 2 hours, a normal time to enter rapid eye movement sleep is around that time. And, when you say you wake up with a headache, I find that particularly interesting because that is one of the signs of obstructive sleep apnea. And you don't need to snore all the time to have it. But it is interesting. And we tend to, in rapid eye movement sleep, especially if the airway, your airway is more vulnerable to relax and close off during that stage of sleep, because essentially there's a switch in your brain that says your brain's going to be super active and you're about to go on some wild ride with all these dreams. So you need to be paralyzed.
Mm-hmm.
So a lot of our upper airway musculature, this is all muscles that go to sleep in mean, we still breathe because we have a diaphragm that functions, but everything else really essentially gets paralyzed. So our airway is at its most vulnerable, and it's sometimes a trigger for people to wake up because they may be okay or have relatively mild sleep apnea, meaning fewer events during non-rapid eye movement sleep. But when we move toward rapid eye movement sleep, our airway can start closing off a lot, and that can be a trigger to wake up. And again, some of the symptoms include a headache when you wake up. So I would, I would argue, why not be curious and get a sleep study and just see,
Yeah. So where does someone go to get a sleep study, or
You
how do you get a sleep study done? So I'm like the ideal shill for this.
well,
I
there
didn't
are
intend it that way, but it's just happened to work out.
Well, what I would say is there are many ways to work with a sleep provider, and there are primary care providers that are comfortable ordering this type of testing. I I think they need to be also pretty comfortable with managing what you do if you do find it. Everybody has a different workflow, but sometimes it's through the primary care doctor. If you're speaking specifically, of course, I'm biased because this is my area of expertise, and you want to work directly with a sleep provider, you can go to somebody in your community. Sometimes there's a long wait list because there's not that many of us. The other alternatives, and this is one of the reasons why I started my concierge practice, is there are a number of telemedicine companies. So I started the concierge practice very specifically to help those who really wanted to take a deep dive and they just need more time. There's no pressure for time. We are spending time together. We're really unearthing what's going on with your sleep. I can practice outside the traditional model. I also joined forces with Agnomi Sleep, which is a telemedicine company. So I'm able to see patients in various states and specifically New York, New Jersey, Georgia, and California. And what I can do through Agnomi Sleep is a very traditional medical model, but I know the people that I'm working with. I know we are trying to deliver quality care. I'm a medical director there, and I'm very proud to have partnered with them because I really think it's a quality sleep company. So you can use a quality sleep company that's going to go over those results with you, that you're going to have that personalized experience. And then, of course, just making an office visit in a traditional insurance-based model as well. It may take a bit of time, but it's worth it. Many times we can do home sleep apnea testing, so you can be screened and do a test in the comfort of your own home. There are limitations to the accuracy of home sleep apnea testing. Technology is always improving, but it's not perfect. And when we have further questions or further issues, we can always explore getting you into an in-lab sleep study, what we call a polysomnogram, where you can come overnight and we can hook you up with electrodes and watch you in the lab too.
Mm-hmm. So how do you do that using telemedicine? So let's say, for example, I might be your ideal patient. Is everything that you do private pay, or do you also do insurance type situations?
With Oak Health Center, which is a concierge practice, that is, I create hours for you. You can work directly with me. We can email and correspond back and forth. It's a very intimate patient-doctor experience. For the traditional insurance-based model, which is Agnomi Sleep takes a lot of different insurances. So through that plan, you schedule a visit. I see you in consultation. Bill your insurance for said, visit. And it's a very traditional intake, sleep medicine consultation, very standard. And it's perfect, especially for obstructive sleep apnea, because there are 24 million people in this country estimated to have moderate to severe obstructive sleep apnea, meaning that their airway is closing off at least 15 times an hour, if not more. There's 60 minutes in an hour. If your airway is closing off almost every other minute, you got a problem. And there's 24 million Americans running around. And to your point, we are capturing 20% of them. We're missing 80%. And, it might be a lack of opportunity, a lack of resources, or just pure need for education, which is why we're having this talk today.
Exactly. And I'm the perfect person to have the talk with, someone who has some sleep issues, as many people do. I'm not at all unusual. So So if you say you do the diagnosis and let's say we do something at you did something at home, one of your patients would you usually do if a patient comes in uh, or potential patient comes in and you have a discussion with them, what about a consult? Do you do a free consult, or how does that work if you're working with somebody new?
Everybody gets an initial consultation. So that is a formal consultation that, yes, the patient does pay for that consultation. We make sure that all of our documentation is where it needs to be in order to get it approved through insurance. And I do the same level of documentation regardless of whether you're in my concierge practice or you're just seeing me in the office. It's just my style to make sure I'm being as thorough as I possibly can in my documentation. And then we send you home with a home sleep apnea test. And when it's done via telemedicine, we typically will mail the equipment and make sure the patient feels comfortable using the equipment and being tested with the equipment. And then the way technology works a lot nowadays with the specific types of devices that we use, often the uploads may be virtually automatic, so we get a real good sense of what's going on with your sleep very quickly, and then we can get you in to see you very quickly to go over those results. I really find it's very important to have a face-to-face with results, even when the test is quote normal. Because
Hmm.
as I mentioned, there's some limitations to home sleep apnea testing. And so even in a person who might be very obviously a sleep apnea patient, they scream every symptom in the book. If you have a completely negative home sleep apnea test, it's important to discuss the fact that we might be missing it, even in that person, in about 10% of the cases, roughly, depending on the device accuracy. So these tests aren't perfect, but they are a great tool that is so easy to at least screen, and that can bring up the discussion of whether or not we need to do more thorough evaluation. We can also there's a lot of ways to treat you without you needing to go somewhere as well, in terms of just treatment options with our CPAP machines that we have nowadays that have modems and they transmit data. I mean, sleep is just a really fun world because of all the fun tech that we have these days.
So let's talk about CPAP machines. So I know about CPAP machines to a certain degree. I mean, well, I want to ask a different question, then we can go to CPAP. Is there a genetic component to sleep apnea? So, like, is it a familial trait that will be passed on from family members?
The short answer is yes. The longer answer is it's not like we're screening you for a particular gene that's going to tell you that you're going to have sleep apnea. It's more that we're all shaped and built differently. And when it comes to how our airways are, we tend to look like people in our family. So there does tend to be a trend of sleep apnea running through the family, often because we may have the same body habitus. We may have the same kind of jaw configuration. Our airways, it's basically sharing genetics in terms of how we look and how our airways are built. Our muscle tone in our upper airway, all these little different factors that work together to maybe influence our risk.
Okay, that's interesting. So let's talk about CPAPs for. So I look at those things and I think, wow, that looks like a horrible contraption, some sort of a punishment device. So tell me about CPAP machines and where they are. I know they have there's a new firm that comes out that has an implant, and that sounds scary to me. But tell me about CPAP machines, how noisy they are. Have they improved? How the setup. I look at this thing. It just looks like an astronaut kind of going to the moon with.
I feel like this is less of a podcast and more of a consultation. So here we go. Here we go.
No,
This
but
is the
this is.
ResMed Auto.
I'm asking the questions that your potential patients, clients are really want to know. So this is.
I can just refer them to this episode. So here you go. This is the latest ResMed model that we have. There are other brands out there. I'm just going to show you the one that I have available to
Yep.
you. I'm about 5'2", so you can imagine a lady's shoebox is probably a little bit bigger than this. Okay, this is not
Hmm.
very big. There is a water chamber in the side here. Humidification is always elective, and it's simply to allow there to be more moisture. Some people find that the air is dry. Some people actually feel the opposite. They don't like to use humidified air in their machine. There is a tube that plugs into the back. The newer machines actually have a heated tube. The importance of that is, if you can imagine, water's evaporating, going through that tube. If it cools in the tube, you can have condensation. And then you have something called rain out, where people feel like it's all watery and stuff. So heating the tube can allow the air to, the water molecules to remain more in that aerosolized form without condensing, getting to you. So you get more of that moisture benefit. So it's a comfort feature.
Interesting.
This is generally how it looks. There are a lot of different masks out there. You can probably see, I try not to have too many heads because otherwise my room would be very creepy. But this is just one example, okay, of a mask. They come in different flavors. And really what the vast majority of units that we're ordering, the machines now are so sophisticated that they're called auto CPAP machines. CPAP stands for continuous positive airway pressure. When you and I breathe right now, we're sucking in air into our lungs. We're generating negative pressure. When we go to sleep, we're still generating negative pressure to breathe, but now we have this airway with sleep apnea that's closing and collapsing. So we're breathing and trying to generate negative pressure, but our airway is closed. So these machines use air pressure to stent, open the airway. It's using air to keep the tissue open. So now you have an open airway. The way it works is you have a closed system, right? If you have air escaping, all that air pressure is not going to do anything. So it actually results in an incredibly quiet night, particularly for your loved one who is sleeping next to you with their eyes going, OMG, I cannot stand their snoring. It's making me insane.
I want to put a pillow over them.
Believe it or not, I've had so many people actually say that their spouse almost has to check on them because they're so quiet. The spouse is like, are you okay? Oh, wait, they're breathing. Oh, they're quiet. Oh my goodness. So it's actually something that your spouse has to reacclimate to for you to be so quiet. The units themselves, if you've got, good tubing, good seal, they're very, very quiet, actually. I mean, the actual intrinsic machine does not make very much noise at all.
Okay, so enough about my specific thing. Let's talk more about you. So you said, but
We're
this
done
is really
with sleep
interesting.
consultation. Moving on.
So you studied psychology at Barnard and got your MD and MPH at Tufts, and then you trained at Cedars-Sinai and UCLA. You could have gone into almost anything. What pulled you towards lungs and ICU first?
Or, the traditional way people mostly think about medical students, and I'm sure it's still that way today. You go, you do your undergrad, you do your pre-med courses, you're a really smart person, you take your test, they accept you into medical school, you may do some extracurriculars that get you there. As a psych major, very, very long time ago, that was not a good idea to be a psych major and try to go to medical school. It was like you were a biology major and nothing else. It was a very specific model. Yeah. And honestly, the pre-med committee at Barnard College basically told me that you were going against the model. We are not supportive of that. And so I connected. I was like, I don't know what I'm going to do because I'm still going to apply even if I don't have your support, because that's my personality. And lo and behold, there was somebody in the psychology department, Dr. Robert Ramez, if you're listening, I just love you. I know he's still there. He was a great mentor to me. And he's like, by the way, I happen to be on the pre-med committee and I want you to be my TA. I'm very impressed with your skill set. I think you're really, really a natural. He did the biopsychology course. So through him, I was able to garner the support I needed, even though it was sort of off the beaten path. And one of the things that made me off the beaten path was I chose to actually work for a couple of years before I actually applied to medical school. That was a personal decision. I felt like I just wanted to get a peek under the hood of what it's like to be working with patients. My opportunity to do so at that time was to become a pulmonary function technician. That's the person who does breathing tests on you. So it was my very first experience was to work side by side with pulmonologists. I learned what bronchoscopies are. Those are procedures where we go in with a camera and we may take samples of tissue in the lung and clean it out if there's mucus and other things. So I got this experience into lungs. I can assure you that when I left that, I was like, I had to clean the bronchoscopes. I was cleaning all the equipment for this stuff. I'm like, ugh, this is so gross. I'm never going into it. Then I'm in medical school and I'm learning about all these different avenues of things, minus sleep. Didn't know that existed at the time. And I was like, I'm naturally good at pulmonary. Maybe it was that prior experience and exposure, but I loved interpreting pulmonary function tests. I went in the ICU and I would see all of these people on these drips and drips and drips. And I'm like, how does anybody do this? They must be like geniuses that they can keep people alive in the units on these machines. And it really was out of tremendous respect for the people I worked with at Columbia University, all of those skilled pulmonary critical care experts, that I said, I want to be like them because I think they're really smart. And if I can do that, then I know I'm really smart.
Mm-hmm.
That's how it started. And it was, it really was. I also like the acuity. I'm not a very patient person. And I don't like when I have to wait for labs and wait for imaging. I like to be able to order everything stat and have a reason for it, because then I can figure out and solve the problem faster.
So I got a little bit of how you transitioned from, but I didn't really get the real inside story of, so you're in the ICU and then COVID happens and then you somehow ended up being a sleep doctor. How did that, what was that transition? It wasn't like, you weren't struck by lightning, or maybe you were. How did that happen to go from the ICU to sleep doctor?
Well, when I started on my journey toward, actually becoming an attending, right? And you dabble, you always have the umbrella of being a fellow and having an attending who ultimately makes those decisions. Then you become the big bag attending. You're going to make all those decisions yourself. One of the opportunities I had out of sleep fellowship, because it's pulmonary critical care is one fellowship and then sleep is the other fellowship. Once I was done with all of that training, I honestly, after that year of sleep, I was like, I still love the ICU because of the intensity and the patients are interesting and it feels really good and rewarding when you can save a life. I mean, that's kind of like a high, you know what I mean? Like you feel really good about yourself. But I really loved sleep, and I had the opportunity to build from the ground up a program. And as a young female physician being given the opportunity, you are sleep fellowship trained. We want you to build a program that we do not have in New Jersey.
Where was this?
This is in New Jersey. There's an unmet need for that. And I ran and built that program, and it was an amazing learning experience. I mean, literally, it started with just me. And by the time I chose to transition away from ICU medicine entirely, there were about 8 sleep providers at the time at my particular institution. So the transition for me really was about a chronic accumulation of, and we alluded to this earlier, but to circle back to the question of my insomniac issues, I would spend 3 to 4 weeks, depending on the call cycle, really not getting paged. I did my work. I had a very busy practice. I would go home, spend time with the kids, and that was that, right?
Mm-hmm.
But then I had my week of 24/7 ICU call. And I had been doing that for a very long time at that point. If you include all the residency training and everything, we were, getting it nearing close to almost 20 years of doing that. That takes a toll. It is very difficult to get paged in the middle of the night and with residents who had different comfort levels and being able to explain what was going on. I'm the attending. I'm the final say. I need to make sure that patient is stable. Right. That may mean looking at my blue light computer to go over labs, look at imaging, whatever it might be necessary, potentially driving back into the hospital to manage an emergency, and then being expected to show up the next day and work a full day.
Right.
And if you do, so if you do that for 20 years You're tired. And then you go into the pandemic, and it being in New Jersey, anybody in New York and New Jersey, we were wave number one. We were the guinea pigs. Let's just dump a serious disease that's spreading like wildfire, that we don't really fully understand all the components of it, and you manage it. I mean, it is difficult enough on one call cycle, that 7-day call cycle, to have one ARDS patient, adult respiratory distress syndrome. That's what COVID caused. It's inflammation in the lungs. Imagine having more than you can possibly imagine. And it was not all hands on deck. It was, you've been picked, you've been picked, you've been picked, you're going in. We have older people, they're not comfortable going in. We have people at different hospitals that don't have privileges here, so they're not coming here. We need people to man the office, they're not coming here. You must do this. I was told what to do. I'm an employee.
Right. Yeah.
So I showed up, I did what I had to do, and that included an overnight call schedule. And I was not asked if that was a schedule that was conducive to me or that was something I wanted to participate in. You were going to take a 12-hour overnight call. 12 hours on, 12 hours off. That's what you were going to do. So I was thrust into this world that I had not been in since my 20s, essentially, or my early 30s. I had 2 toddlers during this time.
Wow. Is your husband kind of like sainted, or?
My husband also happens to be pulmonary critical care. And during that same time,
how do you do?
He was going to Brooklyn. He was driving to Brooklyn every day to manage. He was part of the emergency response team. Some people may recognize that there were a lot of tents. There were, unfortunately, even trucks that were filling the trucks with bodies for people who had died. He was in charge of that. That was his responsibility. So between the two of us, and I would come home, and there were people that I worked with who were very fortunate. They had much more flexible circadian biology than me. I was blessed. I have been maybe not so blessed with very inflexible circadian biology. So you'd ask me to sleep and I couldn't. I'm like, well, what do you do in that case? Well, you can try Ambien, Lunesta, some of these sedative hypnotics to help you sleep. I had largely avoided those for many, many years. And I was like, let me get a prescription. Let me see if this helps. It worked when I was really desperate, when I was a fellow and I needed a little bit of sleep. Well, all it did, I could still hear the toddlers in the background, and, mom brain was not shutting off. And I was just like, I'm completely fatigued, but I am not sleeping. And now I'm like drugged and not sleeping. This is such a hot mess. And I just slowly started to spin. And then I think what people don't realize is that we could go down a whole negative spiral, and it was negative for a while. But really what happened out of that was I started to dream of what I wanted for my life. And then I really started to recognize that I was like, the only thing you really love is sleep. Like the pulmonary critical care stuff, I was done. Like I basically put a fork in me. I no longer wanted to do it. I called it burnout at the time. I think there are a lot of factors that go into that. And I've learned a lot about myself. And I think what it represented was I needed to grow up. And I finally did. I finally said, I'm going to put myself first beyond everyone else, beyond my job. That is not what you're trained to do in medicine. Your job comes first. Your identity is being a doctor. And I chose to reinvent my identity. I was like, I'm going to be a sleep doctor because that's what I love to do, but that's not who Alison is. And so I just started prioritizing what was important to me. And my podcast, Sleep is My Waking Passion, really stemmed from me being in between patients in the ICU. And I would just dream of what I would do if I hosted a podcast show. What would I talk about? And I just started to just dream this dream. And I really made a wholehearted attempt to work with my prior organization to transition to something that was going to be a better work-life balance and more aligned with what I wanted to do as a professional. And we didn't see eye to eye. So again, I chose me. And I'll tell you right now, I would do it again. It was the best decision I ever made. And anyone listening to this, don't ever do something that isn't what your calling and your purpose is. Believe in yourself, because you are going to live a life that you do not regret if you do that.
And you will sleep better.
Heck yes. Amen to that. Yes.
Okay, so let me do some fun kind of rapid fire questions.
I know you asked me,
They're
like,
fun
ended
and-
on like a really serious note. I was like, oh God, we're gonna go. Okay, we want to go through COVID. All right.
Ideal bedtime for you.
For me personally, my
Yeah.
ideal bedtime, honestly, is between 10 and 11. That seems to be my sweet spot.
Melatonin, yes or no?
No.
So
Okay,
go ahead.
that's a loaded question. No for insomnia. Yes, in small doses if I'm realigning someone's circadian biology, but we need to realign where they're getting to sleep. And I might use melatonin for that reason, or in a neurodivergent patient.
Okay. Last thing you do before bed.
I watch TV with my husband. I stare at him as he typically falls asleep. I stew a little bit and then realize that it's okay. He just falls asleep at 9:30 and I'm just not ready for bed yet. Honestly, it happens almost every night.
What keeps you up at 3 a.m. now?
Honestly, rarely anything. Typically what will happen is the key for me is if I'm interrupted. So right now we've got flu B rampaging my household. I am extremely sleep deprived right now. But that 3 a.m. if I hear a kid, something's going on and I have to get up and actually tend to that, that will tend to trigger me having a harder time falling back asleep. My husband often does that for me just because he knows, so that if I'm conscious of it, but I hear him get up, I can relax and go back to sleep. So that's typically is just something going on in the household. So no longer am I paged with a medical emergency.
So one sleep product that actually works.
Are you talking about for a specific sleep disorder or just anything in general?
Anything.
A good pillow.
Okay, good. CrossFit or yoga, which is better for sleep?
I don't know that I can pick one. I'll tell you why. They both work differently. And yoga comes in many flavors, right?
Yeah.
So CrossFit, you're going to be working on major muscle groups. You're going to be lifting weight. That's high intensity. If you're going to ask me my honest opinion, having done CrossFit and having done yoga, I would make an argument that for me, lifting is a really nice way for me to get any excess energy out. And by that, even some of my angry energy too. So for me, anything that kind of lets me externalize things that I feel frustrated about, and nothing like lifting heavy to do that, is great. But the flip side is, on recovery days, if I get an opportunity to do yoga, right now I do a lot of Pilates. I sleep well because I'm working on my breath and I'm relaxing. And so I'm activating, it's more meditation for me. So it's a different form of focus. So I don't know. It kind of depends.
So sleep is blah, blah, blah. Sleep is my waking passion is now in its third season. What's the most jaw-dropping patient story you've featured?
It's actually in its 9th season, to the point where I have stopped
I'm going to have to get rid
seasons.
of my researcher. That's it. She's
No, it's okay. So I finished season 9, and now we've actually eliminated seasons because we have reached our 107th episode. Very proud of that.
congratulations.
And I would say the most challenging story that I have shared was my very episode 107, but episode 106. This isn't really a patient story per se, but I have a dear friend of mine that I used to work with, and his son, unbeknownst to him, actually had an alcohol problem and was mixing kratom on top of it. And that led to a cardiac arrest. And that cardiac arrest, the precursor to that was very disturbing breathing. It looked like a mixture of both obstructive and central sleep apnea. And how do I know that? Because my dear friend texted me a video and I said, wake him up. And literally, he turned blue. We could not wake him up. That led to CPR, calling of 911. Xavier's alive today because of a text message. So that's the wildest story.
Yeah.
It gets
that
me
is a wild
emotional
story.
thinking about it because I'm just so grateful that he made it through that. It was very scary to watch.
So I like we're run out of time, but I have all these questions still. So it's just going to be into like a Greek tragedy. We don't have the answers to all the questions.
You have to bring me back on. I'd love chatting with you some more.
So if somebody wants, they know where to get to your podcast. Sleep is my waking passion. I'm sure it's on Apple and Amazon and Spotify and every other
YouTube. Please, YouTube.
Yes.
I'm pushing that 100K subscribers. Help me out. Subscribe.
Okay.
You'll learn a lot.
So, and then if somebody wants to contact you about your sleep medicine services, how do they get in touch with you there?
We just set it up. So I'm very proud to announce you can go to askthe.sleepmd.com/work with me, and it'll pop up there. It'll give you all the information you need.
I was not hired to plug this. It just worked out that way. Okay, Alison, thanks a lot for coming on the show.